Okay, I think we will go ahead and get started. I'd like to welcome everybody to our webinar on healthcare access and inclusion. It is being sponsored by Services for Independent Living in the Cleveland area and by the Access Center for Independent Living in the Dayton area. I'm Jackie Stromberg. I am the PCA and Communications Coordinator at Services for Independent Living. And our speaker today is Maria Matzik from the Access Center in Dayton. Before we jump into hearing Maria speak, we'll go through a couple housekeeping rules. Everyone will be muted during the webinar. If you do have questions, please feel free to enter them into the questions box. We will answer as many as we can at the end. If you'd like to see a recording of this webinar, it will be available on our website, www.sil-oh.org, or we also have a YouTube channel it will be on for Services for Independent Living. We are offering 1 CEU credit for licensed social workers, licensed independent social workers, and social work assistants. At the end of the webinar, you will have a survey, and there is a question on there that you need to check yes, you'd like a CEU, and we will get that certificate to you. It may take about 3 to 4 business days. So don't panic, you'll get it, especially with a holiday weekend this weekend. So expect that at the beginning of next week. As I mentioned, there will be a satisfaction survey at the end. So even if you're not getting a CEU, we'd really like for you to fill it out. It gives us an idea of how the webinar went and any other topics you might be interested in for the future. And also, if you notice in the handout section, there is a copy of the PowerPoint we are using today that you can download. Okay, like I said, our speaker today is Maria Matzik, and she is from the Access Center for Independent Living in Dayton, and I am very excited to hear her speak on healthcare. And Maria, I will turn it over to you.
Great, thank you, Jackie. I appreciate the invitation today. Next slide, please. So for everybody's information, I'm Maria Matzik. I'm the Education and Advocacy Specialist with the Access Center for Independent Living in Dayton. This is my contact information. You are welcome to email me with questions, follow-up comments, or just to engage in any type of advocacy efforts. Next slide. So I like to start out by just telling folks a little bit about myself. I think that we get so caught up in everybody's titles and role that we don't really think of people as an individual. So I always start out with who I am. And I identify as a proud disabled woman. And I'd like you to note that I said disabled woman, not woman with a disability, because I identify with my disability. For me, I am proud to have that disability. I'm a disability rights advocate. I identify as CRIP. And for me, that is a cultural identity that links me to the disability community, to my family members in the disability community. I have a life partner of 25 plus years. Um, I identify with the pronouns she, her, hers. I love animals. I have 5 cats, so I am a mother of many fur babies, and I identify proudly as a strong friend. Strong friend. I also think it's important for people to recognize individuals with disabilities as employers, employees, taxpayers, homeowners, etc. I think that we get lost in the fact that we have a disability and people don't see us as a person just like everyone else who does the same things to live their life. Next slide. So I just wanted to show you a few pictures of my life. On the right, this is my partner and I, Alan, in the woods. The top left is part of our backyard outdoor sanctuary. The bottom left is me at a Ohio budget protest, and the bottom middle is me enjoying one of my favorite holidays, which is Halloween. Next slide. So just a very brief overview of my story. I have spinal muscular atrophy type 2, which is a form of muscular dystrophy. It's a genetic disability, a neuromuscular disability. I've had it my whole life, but I was misdiagnosed when I was born with a terminal form of muscular dystrophy. So essentially, my mother was told that by the time I was 2 years old, I would die. My mother was a very strong Catholic, and so she turned to her faith for her support. She was a single parent, so she had a lot of challenges to face in raising me and dealing with the medical profession. Obviously, I didn't die at the age of 2. My mother thought that was just a miracle. We found out later that it was a wrong diagnosis, and I didn't have a terminal form. So there were a lot of things that probably should have been done to help the quality of my life at a younger age that was not done. All in all, I got the treatment I needed at age 16, but it did leave me in a position where I became ventilator dependent, got a tracheostomy, and had to adapt my life to a lying down position. There were a lot of fights that we had to face along the way for the right to education, for the right to good quality health care, equal access, community accessibility. I was hospitalized in 1993 with respiratory failure, and I was asked at that time if I had advanced directives. I didn't understand what that meant, so they explained to me what that was. And I said very quickly, well, no, I don't have a DNR, which is a do not resuscitate, because if something happens, I would want to be resuscitated. I was quickly told that I had no quality to my life, and because of that decision, if something were to happen, I would not be resuscitated. So that was a big eye-opening experience for me. I didn't understand how quickly a person with a disability could be deemed as having no quality to their life. And so that was a turning point for me in my advocacy. There were many medical errors made along the way that has impacted my health, and the prognosis of where I could have been today as opposed to where I am. That doesn't mean that I feel like I haven't had a good chance to live the life that I wanted to, but it does show me that because of my disability, that people view me as less than. And then recently, I've endured some challenges with finding the appropriate accommodations for me as an adult. Facilities, clinics, they don't have the accommodations to appropriately provide the examinations that I need. So I've had a lot of issues with trust in the medical profession. And this brings me really to why I advocate. Next slide. So I want to just go over a little of this with you. And this is going to roll in slowly. So Jackie, you could keep advancing. So a little history worth knowing. In this century, democratically elected state legislatures have referred to people with disabilities as antisocial beings, unfit for companionship with other children, a blight on mankind, a danger to the race, a misfortune both to themselves and the public, required to be segregated from the world, a defect wounds our citizenry 1,000 times more than any plague, and do not have the right to liberties and to liberties of normal people. In a book called The Bargain, that was written by Dr. Paul Longmore, who unfortunately has passed away now, but he was a wonderful scholar and humanitarian. He wrote this: deaf people were forcibly prevented from using sign language by teachers in schools for the deaf and punished severely for infractions. In the 1930s, over half the states, oops, could you go back, please? Thank you. 1930s, over half the states had adopted sterilization laws on people with some disabilities. And during the 30s, in Germany, tens of thousands of people with disabilities were put to death in hospitals by Nazi doctors. They were perfecting the concentration camps and the devices that they used to exterminate thousands and thousands of our brothers and sisters. That was perfected on the disability community. Next slide. So I wanted to point out that not too long ago, in 2004, you can continue, Jackie, that Justice Scalia, which was a Supreme Court justice, said that he saw no constitutional reason why state agencies could not discriminate against persons he referred to as handicaps. Some states may not have made it easy for handicaps to vote, he said, but that's no reason enough for Congress to subject states to lawsuits. And Justice Rehnquist agreed with him. So I think that's pretty profound for us to understand the view that our legislatures have had, and as recently as 2004, and if you look in the searches for today, what is being said about people with disabilities. Next slide. So now you know me. Let's talk about the facts. So there's some key facts you should know. There are over 1 billion individuals, which is about 15% of our world's population, that have some form of disability. Between 110 million and 190 million adults have significant disabilities. Rates of disability are increasing due to population aging and increasing in chronic health conditions. Now, I wrote this, or I did this presentation before the pandemic. So the numbers I'm giving you are actually higher now. 1 in 5 Americans is a person with a disability. Next slide. So disability is a natural part of the human existence. Disability can occur at any point in our life, and it can range from mild to severe. And the World Health Organization recognizes that what defines individuals with disabilities, their abilities, and their health outcomes more often depends on their community. Next slide. The World Health Organization defines disability as a functional concept. Disability is any long-term limitation in activity resulting from a condition or a health problem. This is the recommended international standard for data collection on disability. And it's important to understand that people with disabilities are diverse. We are not all the same, and we should not be viewed as all having the same needs, wants, desires. But we do share an experience of living with significant limitations in function, and as a result, often experience exclusion from full participation in our communities. And a diagnosis of a disability shouldn't define us. Now, I know I said earlier that I do identify as a disabled woman. I do that. But I shouldn't be defined just because I have a significant disability with limitations. Next slide. So I have two little graphs that I think really show a great image. So the graph that's on the left is what we like to call the medical model perception. The graph on the right is an independent living model. So on the left, you're going to see that society views our impairment as our problem. And as a result, we have to have specialists and doctors, social workers, child development teams, special schools, PT, OT. All of these individuals are who create our identity. On the right side, on the independent living model, we say that the problem is society. It is not our disability. It's the lack of education, discrimination in employment, segregated services, the need to be to maintain a level of poverty just to get the services you need, inaccessible transportation, inaccessible information, inaccessible environments overall. Next slide. So let's talk a little bit more about what the medical model looks like. So the medical model focuses on the lack of capacity to function. So that's specifically about the individual and their limitations. There's an emphasis on impairment in physiological and psychological body functions. The impairment on anatomical or biological structures. And any intervention is approached from an individualized medical perspectives with outcomes that focus on health and illness. Next slide. So in the social model, what makes someone disabled is not their medical condition, but its attitude and its society. Society disables us. People view us as unable, incapable, and inferior, like you saw in the list of the history comments that I had. The social model takes a civil rights approach to disability. Society disables people with impairments or medical conditions. The social model focuses on improving the quality of life for people with disabilities. And people with disabilities have less access to healthcare services and therefore experience unmet healthcare needs. Next slide. So let's talk about some specific healthcare needs that people with disabilities have. So essentially, it's the same as everybody else. We need preventative medicine and screenings. We need physical fitness. But in addition, people with disabilities sometimes require specialized care for their specific disability. And they may have additional medical conditions that require attention. Next slide. Health promotion and preventative activities seldom target the disability community. Women with disabilities receive less screening for breast and cervical cancer than women without, because examination tables are not height adjustable, and mammography equipment only accommodate women who are able to stand. Now, there are some places that do accommodate people in a sitting position that they can bring their wheelchair up to have a mammogram. Again, in my condition, my situation, that still wouldn't work for me. People with intellectual impairments and diabetes are less likely to have their weight checked, and adolescents and adults with disabilities are more likely to be excluded from sex education programs. Next slide, please. So let's talk a little bit about barriers to healthcare. There's prohibitive cost. There's the affordability of healthcare services, transportation issues, and then there's the lack of appropriate services. So in this, we see that 51 to 53% of people with disabilities compared to 32 to 33% of people without disabilities are unable to afford any type of health care. That's a huge difference. Next slide, please. Some of the physical barriers to getting adequate or appropriate health care, the access to buildings. Most hospitals and clinics and health centers still have limited access, inaccessible medical equipment, inaccessible exam rooms, poor signage. So for individuals who are blind, they most times there are not braille indications, or individuals who are deaf. It's a challenge for them to have an interpreter with them. Narrow hallways and doorways, and inadequate bathroom facilities. Next slide. Specific healthcare needs. So some additional barriers. People don't always think about some of these additional barriers. Just getting to the appointment. There's a lot of things a person needs to go through to get up, get ready, and actually get to the appointment. Getting into the building, checking in for the appointment. Some folks can't get up to the counter, and if they can, they can't do the check-in process without assistance. Completing paperwork. I don't know how many times we've had somebody at an office just hand us a clipboard, and if I didn't have somebody with me, I couldn't fill that out. Again, maneuvering through the clinic and the exam room and the appropriate communication, accommodation. Next slide. So I want to just give you a little snapshot right now, because there are a lot of people that rely on some sort of home care service, whether it's a nurse or a personal care assistant or homemaking service. The national average as of January 8th, 2021, the average annual pay for a fast food worker in the United States was $22,485 a year. So that works out to be about $10.81 an hour. The national average for a home care worker in 2020 averaged to $10.68 an hour. So that's under what a fast food worker makes. Next slide. And again, I want you to remember that this was done before the COVID pandemic. So these numbers are much higher. An estimated 12 million people in the United States require some sort of long-term care. Nearly half of those requiring care are under the age of 65 years old. Women are disproportionately overrepresented in the lower income brackets and underrepresented in the higher income brackets. And Americans are living longer. The Ohio population, the average is 85 years. Next slide. So here's a little snapshot of what home care supports look like. It's the assistance with daily tasks, such as eating, dressing, bathing, and toileting, errands and household chores, skilled care such as bowel and bladder routines, tracheostomy care, wound care and medication, and social support to assist individuals to participate in the community. Next slide. So why am I telling you all this? Next slide. So it's important to understand what an individual goes through before they ever see a medical professional or go to any kind of appointment. And home care is the beginning of where it starts. So when a person is facing their daily activities, they have to go to an appointment, a meeting, they have to schedule their care. They have to depend heavily on their caregiver's reliability. What if the caregiver doesn't show up? They have to plan out the amount of time it takes for them to get ready for that visit, for their cares. How far is that appointment? And depending on transportation, if it's public transportation, how early do they have to leave? Planning for their procedures. What equipment do they need? Who has to go with them to help? Discussions, they have to have discussions regarding any accommodations that they might need for that appointment and whether or not those accommodations will be granted to that person. Telehealth and technology. Though telehealth has opened a lot of doors for people to be more inclusive, it also has created a barrier for some. Some folks didn't have the technology that they needed to participate in that service. Their insurance coverage and prior authorization. They have to understand what their insurance covers and what's required for coverage. And appropriate care coverage for after procedures. So I think that people don't realize when you have a procedure, that could change your routine drastically. What does that look like for your caregivers and for your care needs? Next slide. So factors that become important once the patient's in the office. The ability to communicate their health needs effectively. We know how quickly a care provider comes in and out of the exam room. Not everybody's given the time that they need to actually communicate everything or to understand everything. The ability to receive an appropriate and thorough examination. And again, to spend the sufficient amount of time with their care provider. Next slide. So once that person leaves that appointment, then what? They have to be able to obtain their prescriptions, get to any therapy or specialty care appointments, be able to keep or make follow-up appointments, access groceries. And I know people think, well, what does that have to do with healthcare? Well, you have to have proper nutrition to maintain good health and then be able to participate in community activities. Next slide. So again, some statistics. 1 in 3 adults with disabilities are the age of 18 to 44 years of age, do not have a usual health care provider. 1 in 3 adults with disabilities 18 to 44 years have an unmet health care need because of cost, and 1 in 4 adults with disabilities 45 to 64 years did not have a routine checkup last year. Next slide. So on this slide, we see that 2 in 5 adults age 65 years or older have a disability. 1 in 4 women have a disability. At a national level, Native Americans have the higher disability rate among working age adults. African Americans are next at 11%. Caucasians are next. And then Hispanics, and then Asian Americans. And more than 1/3 of the LGBT community, adults, identify as having a significant disability. Next slide. So to be healthy, all individuals with or without disabilities must have opportunities to take part in meaningful daily activities. This will add to their growth, development, fulfillment, and community contribution. So meeting the disability and health objectives over the decade will require that all public health programs develop and implement ways to include individuals with disabilities in program activities. Next slide. Until recently, people with disabilities have been overlooked in public health surveys, data analysis, and health reports. So that's made it very difficult to really bring about the awareness of the dramatic disparities in healthcare for people with disabilities. There's emerging data indicating that individuals with disabilities experience health disparities in routine public health arenas, such as behavioral health, clinical prevention services, and chronic conditions. Next slide. So let's talk a little bit about advocacy. From Wikipedia, self-advocacy is speaking up for yourself or for your interests. It's used as a name for the civil rights movement and mutual aid network for people with disabilities. The term arose in the broader civil rights movements of the 60s and 70s and is part of the disability rights movement. Next slide. So what is a self-advocate? Someone who speaks up for themselves. Someone who makes their own choices about their life. Someone who learns how to get information and resources. Someone who understands their rights and responsibilities. Someone who identifies and creates a support system. Someone who reaches out to others when they need help. And someone who problem solves, learns listening skills, and develops self-determination. Next slide. What is a self-advocate? Is self-advocacy in healthcare. So for patients, self-advocating provides an opportunity to get your needs met, to voice your preferences, and to maintain a level of control over your life. For the provider, self-advocacy suggests that the individual is competent in managing and preventing health problems. Next slide. So I like this. We're not broken. There's no fixing needed here. We just need to embrace the beauty and wisdom of disability holds for us. So can you be your own advocate? Becoming your own best advocate takes time and practice, but you can do this. The more you advocate for yourself, the better you will get at it. Advocating for yourself means knowing what your needs are and speaking up for yourself to get those needs met. But it takes practice. Next slide. So, what can you do? Understand yourself and what your needs are. Identify those needs. Ask for them to be taken care of. Don't wait for someone else to do that or expect them to advocate for you. Come up with ideas about how you can get your needs met while respecting others' time and abilities. And don't give up because the process is long or the situation is too hard. Next slide. So here are 7 ways to advocate for your health care. Ask questions. Ask about the benefits, side effects, and disadvantages of a recommended procedure. Understand how your health insurance works. Do your own research. Maintain your own records. If you're not certain, get a second opinion. Review your medical records and know your rights. Next slide. What can physicians do? They can provide a broad range of modifications and adjustments, which would be reasonable accommodation, to facilitate access for healthcare services. They can change the physical layout of clinics to provide access for people. They can offer accommodations for communicating health information in accessible formats. Offer interpreter services. Offer in-home accommodations like X-ray, ultrasound, and lab work. They can promote community-based rehabilitation. This would facilitate access for people with disabilities to existing services. And they can empower people to maximize their health by providing information, training, and peer support. Next slide. So for human services, places of higher education, medical directors, they can integrate disability education into undergraduate and continuing education for all health care professionals. They can train community workers so that they can play a role in preventative health care. They can provide evidence-based guidelines for assessment and for treatment. They can identify groups that require alternative service delivery models. They can include people with disability in healthcare surveillances. And they can conduct more research on the needs, barriers, and healthcare outcomes for people with disabilities. Next slide. So I leave you with this. Advocate, advocate, advocate. Never stop advocating. Learn to listen. Don't just hear. And please, by all means, communicate and ask questions. Don't ever just make assumptions. Next slide. And then I just provided a list of the influences that I've had in my life and who have helped me develop this presentation. If there are any questions, I would be happy to answer them.
All right, let me check the chat box. If anybody has any questions, feel free to enter them into the question box or the chat box. Nothing right now. I noticed, Maria, you had some great resources at the end, didn't you?
I did, yes. I provided all of the links to the information.
Yeah. There is a lot there.
And Jackie, if you go back to that photo, I didn't really touch on it. I just wanted to show everybody like the parallels over the years in the different civil rights movements. So on the top left, we have Dr. Martin Luther King and the civil rights movement. On the right side, we have the disability rights movement and ADAPT. On the bottom left, we have the Black Lives Matter movement. And bottom middle, we have the LGBTQ community and gay pride. So I just want you to see that there's not a lot of difference in these pictures. There's differences in how people have experienced prejudice and injustice, but the fight is the same. And if we all came together, what a powerful voice we would all have.
I don't see any questions. I just have I've seen a few comments about how people enjoyed the presentation. I'm having a little screen difficulty here. And Maria, you are very inspirational and a great advocate for others and for yourself. That was,
Well, thank you.
That was very, very nice. I won't tell who said it. Any other questions or comments? Okay, well, we'll give everybody a few minutes back. Please feel free to download the PowerPoint handout if you desire. Again, there'll be a copy of the recording on our website, sil-oh.org. Or if you're on YouTube, we have our own YouTube channel, Services for Independent Living. And remember the survey that's going to pop up at the end. If you'd like a CEU for those social workers out there, please fill out the survey and check that box so we can get that to you in the next few days. And even if you're not looking for a CEU, we'd appreciate your feedback and interest in other topics that it's important to us. So we're reaching and discussing things you want to talk about. So I don't believe, I'm going to check the box one more time. I think we are good. We got to thank you for presenting. You're amazing.
Thank you for having me.
Well, I'm very glad we had you. It was wonderful. Definitely learned a lot about advocating for yourself, especially with healthcare. So,
Yeah.
All right, everybody, we will let everybody go. We appreciate you attending and have a wonderful rest of the afternoon. Thank you.